people can join in. So it's my pleasure to introduce you all in a thorough way to our partner, Gary Albrecht. Now, Gary's one of those people that I could spend the whole hour actually doing a bio on him. So I'm going to try to keep it relatively brief, but just to show you the vast experience he's had in terms of the topic he's going to share today. So Gary is a fellow of the Royal Belgian Academy of Arts and Sciences, extraordinary guest professor of social sciences, University of Leuven, Belgium, and professor emeritus of public health and of disability and human development at the University of Illinois at Chicago. After receiving his PhD from Emory University, he served on the faculties of Emory University in sociology and psychiatry, Northwestern University in sociology, rehabilitation medicine, and the Kellogg School of Management and the University of Illinois at Chicago in their School of Public Health and the Department of Disability and Human Development. Now, since retiring from the University of Chicago in 2005, he divides his time between Europe and the United States. He works in Boulder, Colorado, and Brussels, Belgium. And he was recently a scholar in residence at the Maison des Sciences de l'Homme in Paris, a visiting fellow at Newfield College, the University of Oxford, and a fellow in residence at the Royal Flemish Academy of Science and Arts, Brussels. His research is focused on how adults acknowledge, interpret, and respond to unanticipated life events such as disability onset. This work has involved studies relating to the traumatic onset of and adjustment to paraplegia, disability culture, stigmas regarding disability, quality of life, onset of disability during and post-menopause, HIV AIDS as a disabling condition, access to and rationing of care for disabled people, interactive relationships between disabled people and professionals, and the political economy of disability and rehabilitation. His work, supported by over $25 million of funding, has resulted in 16 books and over 140 articles and book chapters. Gary and his wife, Michelle, have been partners with SVP for 3 years and were introduced to SVP by partner Tim Watson. Gary, it's such a pleasure to have you here today, especially with your breadth of experience and knowledge, and especially during this time, during this worldwide pandemic. So with that, it's my honor and privilege to introduce you to Mr. Gary Albrecht.
Thank you very much, Josh. I want to thank you people who are partners. I've been just really thoroughly impressed over the last few years with the quality and depth of people here. So thank you for being part of the group, part of the team. I thought what I would do today is talk about some issues that might affect us individually, and talk about issues and some battle plans, so to speak, to think about how do we deal with our partners in SVP and the people we deal with in the local community. So the particular case study I want to use is one that's very close to all of us right now. It's COVID-19. And it's something I spent a lot of time looking at, pandemics and epidemics over a long period of time and in many different countries. I thought the idea that I would start with is hitting a moving target. And if you take a look at what we're dealing with COVID-19 and many other things, by the way, on the agenda in today's world, it's a very moving target, and facts and opinions are changing very rapidly. So how do we center ourselves, have balance, and address a world that's coming at us? One thing that we can do is look at the past. The past is a great teacher. History is a great teacher. But on the other hand, we don't want to prepare for something that's already happened that may never happen again. And on the other hand, if we take a look at what's going on right now, most of us aren't very sure of what's going on right now. And if we take a look at what's coming up, we also aren't too sure of how it's going to play out. So I like to think in terms of multiple scenarios. And I like to think in terms of focusing on a particular issue or problem. In this case, what I'm going to talk about is COVID-19. And COVID-19 sits in a long panoply of endemics, pandemics, and major health problems that have affected the world. But it's a moving target. And we get all kinds of different information. And we have all kinds of authorities telling us, do this, do that, don't do the other thing. So where I want to start, and this goes to SVP, ourselves, and our community, is I think it's really important to be aware and comfortable with knowing what we don't know. And I say this to many professionals and experts all over the world. What do you know? What do you think you know? And what is it that you don't know? And are you comfortable not knowing? And are you comfortable changing your mind? And in fact, if the game plays out, in fact, and you took a risk and you were wrong, are you willing to admit, gee, I was wrong. I changed my mind and it's just great. I learned something new. So one of my models to myself is in science, be happy to be wrong. Then what do? Well, don't believe everything you think you know. Well, how do you know that you don't know? Well, what you do is get out and talk to other people. You get multiple sources of information. And what you do is you aim at developing a wide diversity of people to talk to about the issues that are really critically important to you. And you listen. And you ask questions. What do you think? How do you know that this is true? What is the problem? How would you approach that? And I think life is a very humbling experience. So Jeff said, use some biographical examples, so I will. So I was what I would call I grew up in Seattle. My father used to talk about young people, my buddies and I, as being junior whippersnappers. That puts you in an age group. And he used to say, oh God, you guys think you know everything. Let me tell you what it was like being in the Depression in the Pacific Northwest. And on we would go. So when I was coming out of graduate school, I received a grant from the World Health Organization in Geneva to compare healthcare delivery systems in different countries that had different levels of resources. So I chose to go to Sweden, WHO in Geneva, the old Yugoslavia, Iran, and Kenya. So fast forward, I'm now sitting in Iran, and I'm with an interpreter, and we're out in rural areas, and everybody has cholera and diarrhea. And I thought, and there's no toilet paper. And I thought, boy, I can make it for a day or two, but I'm here for 5 weeks. So I was asking them, well, how do people live? What do they do? And they said, this is the way we live. We live with this. That diarrhea and cholera is a way of life. And we build up some immunity to it. And well, then how do you deal with that? Well, we go, if we're lucky, and we talk to the elders in our village. This is Iran. We go to the mullah and we ask people at the local mosque, how have you dealt with this over a period of time? We go to our friends and we say, what do we do? And when all else fails, we come and talk to you. I'm with now 2 young physicians just out of medical school and from Tehran, one from Tehran, one from Isfahan, and we're in Babel, which is on the Caspian Sea over the top of the mountains. And so we said, well, if you get sicker, who do you blame? And boy, that caused some consternation. Well, you don't want to blame your mullah. If you get well, who do you blame? And so who do you say, boy, thank you very much for helping? And they said, well, we aren't sure. And they were sitting in Iran, uneducated, they couldn't read and write, and they were searching for different interpretive frameworks. And so this is what I want to then put forth to you. When you find a problem like this and people are dying or people are uncomfortable, how do people interpret where they are? And that comes from an interpretive framework. Branislaw Malinowski is a Polish anthropologist stranded in the South Pacific in World War II, wrote a wonderful book called Magic, Science, and Religion that explains people's thought patterns in Iran, or I'll move forward to being with the Maasai in Kenya at that same trip. And that what they would do, and I think people do that in our own community in Boulder. If they have a problem, they say, oh God, I think I'll go to a therapist about this problem. And if they don't like the therapist, what they say, oh, you know, I made a mistake. I wasted my time on this damn therapist. They don't take my insurance and I don't think they're very good. So I'm going to go to my Episcopalian minister. You go to your minister and he can help you where he doesn't, and you still have your problem. So you say, well, you know, I don't think that's very good. So I'm going to go have to a tarot card reader and have my tarot card done. And so you search around for different people who are in power that you think may or may not help you. And as soon as somebody helps you, then you have to attribute causality to what made me better. And it's not at all clear. So that's why I'm saying hitting a moving target really you have to identify with the people that have the problem. And then you have to run through what are the different interpretations that we have. So let's fast forward to COVID. In COVID, we have preachers, we have prosecutors, we have scientists, and we have politicians, and who are all in this game. And the preachers will tell you, if you have religion, and if you're morally good, you will do X, Y, and Z. The prosecutors will go after why this is or is not true. The politicians will do what is to their benefit at this particular time. I am, for in large part, what I want to do is focus on science. I'm a scientist, I grew up in science, and I want to take a look at the science of COVID as a case study. And the science of COVID as a case study is interesting because it's complicated. And it's complicated by the fact that there's one group in public health that are giving us information and collecting data. Then there's another group in medicine, biomedical group, that is coming up with vaccinations and viral loads and all this sort of business. And then there is another group that are the social and behavioral scientists. And they're interested in behavioral change. And they're interested in risk analysis. So what I am saying is we need to sort through what frameworks we're going to use in addressing a problem. And what science does is it accumulates knowledge. And that can be historical, it can be large data sets, it can be the foundations of artificial intelligence. And then it goes about trying to identify a problem. So Walter Isaacson, who has just come out with this wonderful book, The Code Breaker, on the last two women Nobel Prize winners coming up with the CRISPR technique for cutting genes, said that there are three major scientific events that have happened in my lifetime. He's talking about Walter Isaacson. He's more or less my age. He said the first was a bit. Think Bill Gates. And the second is a gene. And the third is Albert Einstein. He has his great biography of Albert Einstein, is an atom. And then taking a look at what atoms do and how they behave. And so in science, what we do is we pick a problem, we accumulate knowledge, and then we test ideas. So in any one of those three areas, there's lots of ideas that are being tested right now. Then evidence is produced, which suggests interventions, and then we evaluate the outcomes. And then it's the old Fortran programming do loop, do again. And so what science does is stand on the shoulders of giants. And what science does is oftentimes reward what is politically expedient or popular. And yet we find that some of the greatest scientists are those who stood up against the mainstream and said, hey, wait a minute, maybe the the Earth is not the center of the universe. Hey, maybe, and so on. We go through lots of biological phenomena and so forth. So what I'd like to do is apply and take a look at science as it's focused on COVID-19. And what I would like to say, going back to my example in Iran and Kenya, what was really compelling to me is, autobiographically, is sitting at Emory University, working with people at CDC in the late 1960s and early 70s, taking a postgraduate year-long course with a number of physicians in statistics and analyzing large data sets. And we analyzed the first data set that took a look at the relationship between smoking and cancer. And we were all sitting there in our tweed jackets in a seminar room, smoking a pipe and looking at data. And what happened after 3 months is all of we physicians and PhDs sitting there smoking a pipe, looking at the data set on smoking and cancer, stopped smoking pipes immediately. And so that's an example of behavior change. And it's an example of, if you show people the facts, they'll change their behavior. But I learned later in life that's not often true. So now I'll fast forward to the next experience I had, was getting involved very early in the HIV Aids epidemic. So we're sitting in Geneva in 1986. One of my colleagues from Emory in 1981 identified patient 0, who was a flight attendant on Canadian Air Canada. And the question in Geneva at that time is, what in the heck is HIV AIDS? Why are these people dying? Why are their immune systems collapsing? And so they had called 3 groups of us together, one in public health, one in biomedicine, and one social behavioral scientist. The people in biomedicine are people that you know from watching television today and reading and so forth. So who are the people in that group? Well, they were Tony Fauci. Who were the people in that group? They were the Minister of Health in Mexico. And he is now president of the University of Miami, was head of the Harvard University School of Public Health. Who was in that group? The person who's the head, Christopher Murray at the University of Washington, who's head of the Center on Health Outcomes and Evaluation that has modeled COVID-19 around the world. He's one of the great people who came up with the idea of disability adjusted life years. How does health play out around the world? Who are these people? Peter Piot, who's head of the London School of Hygiene and Tropical Medicine. So going back to HIV AIDS, these are the people in immunology and in medicine who are in the business of vaccines, are in the business of viral loads, are in the business of how did we get where we are and what can we do about it? And they said in 1986, oh God, all you epidemiologists and all you people in social and behavioral scientists are interesting to have on board, but you're basically kind of a waste of time, because we're going to come up with a vaccine if you pour all your money into what we're doing, and we're going to come up with a vaccine against HIV AIDS. And so this is what I say, it's really important to know what you don't know. Here we are, 35, 36 years later, and there's still no vaccine against AIDS. But all of these people in the room learned one hell of a lot about pandemics and epidemics from working on HIV AIDS. And you might remember when you think you can get AIDS from your dentist and so forth, and we began to narrow this down. The people in epidemiology were really good at trying to reach out and get the best available evidence, and at that time 192 countries in the world, and impute what those data meant, what they meant scientifically and what they meant politically. The social and behavioral scientists were saying, hey, look at guys, we might come up with medical ways to treat this business, and we might come up with vaccines, but in the meantime, people are dying and getting very ill. So as of today, there's a little over 25 million people that have died of HIV/AIDS. And where we have come is we've learned how to treat it. And where we have come is we know what causes it. And where we have come is we know virally and epidemiologically, we know the basic science behind it. We know how to build RNA and DNA and how to build messengers. We know how to analyze the attacks to the immune system. We know how to modify our interventions so that our interventions don't overwhelm the body and kill us rather than the disease killing us. So that's what we've learned there. What we've also learned is, with a little humility, is going back and taking a look at epidemics and pandemics. So the epidemics that we know of, and I'm not going to go through them all, you can read that in a number of history books, but one of the ones that was really interesting is in the Iliad is Homer's talking about the plague killing the Greek troops at Troy and what a real influence that had on that particular battle and historical event. You all know about the bubonic plague in Europe. We all know, but we don't talk about it very much, how the Europeans brought smallpox, measles, typhus, and flu to the American Indians, causing 90% collapse in the population in North and South America. So there are all kinds of estimates, but it looks like somewhere between 90 and 100 million Indians before Europeans hit the shores were alive, well, and functioning up and down the Americas, and that was reduced by 90%. Then we had the smallpox epidemic in North America in 1877 to 1977. And then we had the Spanish flu. The Spanish flu devastated the United States and much of the world, and that was named the Spanish flu. Interestingly enough, most of the historical evidence seems to point that the Spanish flu of 1918 began on a military base at Fort Riley, Kansas. But it's really nice to be able to say, in terms of stigma, this came from the other guy. Ebola happened in the Congo. It's a very deadly and devastating disease. And there's about 28,000 people that have died of that. And people in the field are very concerned about Ebola types of viruses because they're so absolutely lethal. So with tongue in cheek, one of my epidemiologist physician friends says, Gary, we need to get rid of about 2 billion of the people in the world to have a good functioning world. And so we don't have these other catastrophes fall upon us. And we need a plague, but COVID-19 is not deadly enough. Well, I'm telling you, Ebola is deadly enough. And then most recently, what we've had is SARS-1. And then we had H1N1, swine flu of 2009. And then what people in the field are always talking about is disease X, and that is something that has the communicability of COVID, but is much more lethal. And we aren't there yet. It hasn't come on the horizon, but it will. So let us prepare. What did we learn historically from pandemics and epidemics? What we've learned is that names matter. We always try and blame somebody else. Remember the Chinese COVID-19? If it wouldn't have been for those Chinese people in Wuhan that let all this stuff loose on the world, we wouldn't have a problem in the rest of the world. Well, WHO just had a team come back from 5 weeks in the field in Wuhan, and there's been a lot of geneticists working on this and so forth. And we don't know. I mean, we really don't know yet, but it looks like this lab in Wuhan is as well run as anything at the Koch Institute in Berlin, or the best labs in the UK, or the best labs at CDC are here. And it looks like it was a animal, happened in a wet market, that looked like it was an animal-human transmission. And so you probably read about the Danish mink who had COVID. We're communicating back and forth. The question they're investigating is, can minks give it to humans, and can humans give it to mink? So what we learned is names matter and attribution matters, and we ought to take it as a community problem. Second thing we learned is quarantine works. Avoid super spreader events. If you get invited, don't go to the next party on University Hill. Socially distance, wear a mask, you've heard all this. Wash your hands. Thomas Mann in The Magic Mountain And the people that founded the leprosy colony on Molokai were very aware of the fact, even in low transmission conditions, that fresh air, outdoor living, and adaptive schooling really worked. Inoculation works. What's also true of viruses is they don't spare the young. So don't believe the fact that children, infants, and teenagers can't get it and can't pass it on to others, can't get long-term COVID, and can't die. Testing and tracing work. The problem with all of this right now is that if you don't measure it and you don't have a test for it and you don't report that, it doesn't exist. And that's where we are with a lot of the numbers that you're seeing with COVID. So let me give you an example. An example would be, how many people have died in Boulder of COVID-19? And I think the number is 249, 250 right about now, right now. The numbers also are, from research being done around the world, that for every person that dies, 5 to 6 will have long-term COVID. And it's particularly true of the young who think they're bulletproof, have no symptoms, and therefore they don't think they can transmit it to somebody else. And they think if they don't have symptoms now, that they won't have symptoms down the line. So we want to multiply the number of people that have died by 5 or 6 by current knowledge, and you'll get the idea, again, some kind of a flavor of how many people are going to have long-term COVID. And that's just based on the first wave of COVID we've had in the United States. The the next waves that are happening, in Europe, they're in wave 3 right now. Italy's totally cut down. So Josh, the reason we're not going back to Belgium is they're going back to hard lockdown because they're in the middle of wave 3 from the South African, the Brazilian, and the British viruses, which all are much more communicable than the one we've been exposed to. So numbers count, but they only count if you measure, and if you don't measure, they don't count. So be very careful of what you hear and what you think the facts are. Then, so that goes from history, that goes to measurement. Then what I'd like to talk about is, hey, are we in a good shape or are we in bad shape? And I say the answer is it all depends on who you're comparing with. So do you want to compare with Taiwan? They've had fewer than 43 deaths with a population of 23.5 million. Do you want to compare with New Zealand? They've had 26 deaths. Do you want to compare Boulder with some other place of the same size? So I'm originally from Seattle. I often compare with British Columbia. The two populations of Washington State and British Columbia are relatively the same. Washington State has 5 times the number of COVID cases counted, as does British Columbia. Is that due to measurement? Is it due to human behavior? We aren't quite sure. So that is, be careful what we know and what we don't know. How do we approach this problem? Well, from public health, the way we approach it is, let's prevent it and keep it from happening. So the public health people think about, how do we prevent things from happening? And this is not a for-profit business, which is very different than biomedical. Biomedical wants to intervene with drugs. They want to intervene with vaccinations. They want to intervene, and it will cost you, particularly in countries that don't have national health insurance. And those interventions will be delivered in a very uneven and herky-jerky kind of way, so that you'll see wave after wave after wave of the virus coming back to get you. The virus is adapting to the host, which is you and I, and the population, figuring out how to infect people. And it doesn't care what political party you're from, what race you're from, what social class you're from, it's at work. So the big fear right now, this is what you're hearing from after the election from the people at CDC and from Tony Fauci, is they're terrified that we're in a race against the variants of the virus. In Boulder, Colorado, we have the British version here. A couple of people have been diagnosed with it. We have a few cases of the Brazilian virus from Manaus in Denver. We have some South African cases in the United States, and it's a matter of time before it gets to us. But we're talking about hundreds of virus mutations that are working right now. And from the public health point of view, we need people to behave. We need people to get vaccinated. We need people to be on board. And if you relax things too quickly, you pay later. And that's what's happening in Europe. Europe relaxed in some countries. Now they're back in wave 3 and they're into hard lockdown again. And historically and epidemiologically, that's what should happen to us. Okay, in the United States, and really in the world, there are 63 vaccines that are in different phases of clinical trials right now that are comprised of 4 different types of vaccines. One is based on whole virus, that's live attenuated viruses. So think back in terms of polio and the different interventions there. One is on the protein subunit, and that's a vaccine for hepatitis B. One is based on nucleic acid, and that's Pfizer, Moderna, and that's all aimed at RNA and RNA messengers. And the 4th group is a viral vector, and these vector vaccines work by giving cells genetic instructions to produce an antigene. And you know most of the companies that are at work on this: Moderna, Pfizer, Johnson & Johnson, Novavax, the AstraZeneca, Oxford. In China, the 2 most commonly known vaccines now are Sinovac and Sinopharm. And in Russia, it's Gamaleya and Sputnik 5. And all these vaccines are predicated on some of this basic science. And the reason the scientists were able to act so quickly and effectively is there'd been a lot of theoretical and practical work done on prior epidemics and on other kinds of diseases using these 4 different types of vaccine approaches. If you want to get accurate information on how this is all playing out, I suggest that you pay attention to the group at the University of Washington. It's funded in large part by the Gates Foundation. There's 2 groups at King's College in London, University College London, the London School of Hygiene and Tropical Medicine, the Koch Institute in Berlin, and so on. And the reason these people are good, in Antwerp there's a group, is that all of these people worked in countries that had colonies. And so they went off and spent a lot of time in the colonies trying to keep people who were colonized from dying because they needed that labor force. So therefore, these different countries, Britain, a little bit the United States through CDC, but Germany, Belgium, Netherlands, and so forth are very used to working in developing countries and dealing with pandemics. So they have very good information and very good knowledge. From the social and behavioral science point of view, what's really important is social network theory. And so Nick Christakis, who's at Yale, is an MD, PhD, runs a behavioral public health biomedical lab at Yale that's just doing absolutely cutting edge research. And he started this when he was on the faculty at Harvard. He took Harvard Cambridge heart study, recoded and analyzed the data. Long story short, fast forward, is you're going to behave as your friends do. If they smoke, you smoke. If they're obese, you're obese. If they don't get vaccinated, you won't get vaccinated, and so on. And so his research has been on how do you change people's behavior? And the answer to that is you intervene not on an individual level, not in a community level necessarily, but through social networks. And you do that by modeling. So that's what's behind people publicly calling for Donald Trump to say, hey, you guys, my followers, ought to get vaccinated, and so on. I want to stop right there. That tickles the brain a little bit shows you some of the history, some of the people that are involved, some of the work that's being done, and gives you an idea of being aware of what we don't know, being happy to be wrong, going with the scientists in terms of letting them gather data, test hypotheses, and keep revising. So the message to the public is confusing to the public because what is the answer? And the answer is we aren't sure yet, and we're in a process. So I think I'll stop it at that.
Thank you,
Josh,
Gary.
there you are.
Yeah, thank you so much. That's quite a breadth of information. We have time now for questions, and it's such a small group that let's raise hands and go. So Mr. Wall. And you might be muted still, Les. Yeah.
One of the things that's hard for me, Gary, is the CDC doesn't agree with you that to be happy when they're wrong. I don't think they like that at all. They are wrong. I mean, they were wrong about masks when this all started. Right. That was a very upsetting thing to me. But one of the things about how, I think transparency is a very important thing. And I don't think the CDC is really big on transparency. I think they want to know things and then tell people. And sometimes it seems like they don't want to tell people things that will interfere with the process of getting everyone vaccinated. And I wondered what you thought of that and what your comments are.
Well, historically, the CDC has been one of the leaders in the world in many of these areas. Oh. But historically, it's also been very politically influenced. And so going to things like this, I wouldn't believe everything I hear officially from the CDC.
I don't.
And the reason for that is the United States Congress will not give any money to CDC to do any research on guns. Try and get abortion studies funded and fetal tissue studies funded through NIH or through CDC. So you have to look in other countries. So what you want to pay attention to, the individual scientists there are on board. And they just go through hell, and they might have to go to therapy, God only knows, because what they know and what they are allowed to say are two very different things. So I have very high regard of the CDC, and the individuals there are absolutely first rate. So not only is this true, but what's also true, they happen to be Americans. And when they go around the world, with rare exception, they parachute in and say, we are here to deliver the truth to you. They don't listen, they intervene. The people I mentioned, Fauci and the rest of these people, Fauci wasn't there, but almost all the rest of them cut their teeth at CDC as young, unmarried men out of medical school doing field work in West Africa. And they aren't of that cut. But that's the answer.
Okay, thank you.
It's political, it's arrogant, and we have the answer.
Yeah.
And there's a lot of things we can't talk about because it's not expedient.
That's a problem. I see that as a huge problem. I mean, I don't think that the CDC is telling us about these different mutations and what the impact is on getting vaccinated, because that might not be pleasant information for us to hear.
No, it's not pleasant information.
Yeah, that's what I figured, but they're not saying that.
No.
No.
Dennis, you had a question.
So, Jerry, that was great. I really appreciate you doing this. You talked about our things we know that we know, the things that we know that we don't know. How about the things that we don't know that we don't know? How do we deal with those? Are they going to sneak up and grab us? I mean, what's the historical experience on that?
Well, the historical experience is, hey, I'll buy my way out of this. Hey, I've got the right religion, and therefore it's not going to affect me. And so all you need to do is take a look at some of the Jewish funerals in Brooklyn. And you need to take a look at people who have a lot of money there was a group who flew by private jet from Colorado to Sardinia about 6 or 7 months ago. I don't know whether you saw that. Got off the plane in Sardinia and said, we're here to vacation. And they said, you're in France and you need to refuel and get out of here. And they ended up in Manchester, England, and then coming back here. So yes, you can buy your way seemingly out of some of this, but the virus is going to catch you because it doesn't know money. And so then the other part of your question is, how do you know what you don't know? Well, that's a very good question. That sounds like an academic question, but it's very good. It probably is. And so what you do is you stay modest about it and you keep looking and you listen to people with other ideas and you collect data in other parts of the world and in your own community to see what's going on. So you'd be going down and taking blood samples from the homeless on Boulder Creek. You'd be taking a look at the people that come into Boulder every day to work who are Hispanic and clean the houses. And so forth. And you do a great deal of testing, tracing, social network kind of things to find out what is it that we don't know and we don't even think we don't know. These people are going back. Everybody who's Hispanic in Boulder County is not Mexican. They're Guatemalan, they're Honduran, they're Colombian, it's get with it. Follow that up. Take a look at it. What's going on? How is this transmitted, et cetera? The University of Colorado is terrible at dealing with this. So if you want to look at universities, look at the University of Washington and the University of Illinois. Both of them has first-rate programs on how to deal with students and COVID. And they sent this out to all the other major universities in the United States. You can use this free, all this work we've done. Only a very few of them took them up on that. Who knows better than we do what's going on here? Yeah.
Lynn.
Yeah, I'd like to also say thank you. We haven't met before, Gary, but it was a great presentation. And my question may be way out of the scope of your presentation, but the part of COVID that is, I don't want to say the word fascinating, but it is fascinating. The whole part about the asymptomatic, the people who are asymptomatic and their role in all of this and what we do about that moving forward. And I guess the question really is there a place to look for information on that sector of society that just don't express the virus?
Yes, there is. And there's lots of material coming out. So you need to go to credible sources. So one thing you want to look at is who are the credible sources? The group at the University of Washington. It's called the Center for Health Evaluation and Outcomes. The center at Brown University under JHA is his last name. He's Indian, was at Harvard. He's dean of the School of Public Health at Brown. They're first rate. Nick Christakis' group he has a book just out on this called Apollo's Arrow. It just came out within the last 3 or 4 months. So you look there. You look at the Mayo Clinic. You look at the American Medical Association. You look at the British Medical Association. You look at Cochrane Trials, which are from the University of Vermont, and those are randomized clinical trials of different interventions. And you look at information that has been vetted by experts. So peer-reviewed published journal articles, where in Lancet, the New England Journal of Medicine, the American Journal of Public Health, the Journal of the American Medical Association, the British Medical Journal, and then there's the Dutch, the French, Institut Pasteur, first rate, Berlin, the Koch Institute. So that's where you look for this kind of thing. I took a bet, and the reason I was involved in HIV AIDS, that we would learn how to keep people alive from HIV AIDS, but that they would linger on for many years with serious disabilities, my interest in disability. That is what my prediction of what's going to happen with COVID-19 is there'll be many people disabled, and many of the people that are asymptomatic will get particularly young people, will get COVID symptoms later on down the line, which are heart problems, lung problems, chronic fatigue syndrome. A lot of research being done right now. What is the relationship for people between people who've had COVID and people with chronic fatigue syndrome, and so on. So we're going to learn a huge amount. You're absolutely right. The most recent research as of yesterday out of Europe was in the UK was they're much better at testing than we are. They tested for COVID antibodies and found out that more than twice the number of people who had been reported to have had COVID actually had antibodies. And that 2% of those were super spreaders who, as you pointed out, had no symptoms themselves. So that's the kind of thing you want to look for. And it doesn't take too many super spreaders who are out in public to give it to a lot of people. And then this is my social network thing. We're not talking about a linear trend, it's curvilinear. You have a funeral, a wedding, you have a party on University Hill, and 5 people get it, and 1 or 2 of those are super spreaders. Within 3 or 4 weeks, you're going to be looking at hundreds and maybe even thousands who have it. Particularly that kind of a group who aren't going to follow what we're saying you should do in public health.
Thank you.
Any other questions?
I have one.
Yeah, David.
Gary, thank
Yeah.
you. Really fascinating. Having worked in medicine or healthcare for a long time, I've come to appreciate how much we've ignored public health, and to Les looks like he's officially become a grandfather now that he's able to play with his grandchild. He's left the picture. I know this was painful for him and Ellen to have to stay away from their new grandchild. The CDC is gagged by politicians, and it's it's one of there are very few government agencies that are really free to speak the truth, and they're not. And your comment about study of gun control. It's just an issue that some politicians won't allow them to do, and the study of AIDS was that for a while. One good thing, and I'd love for you to comment on this, that my friend Cheryl Healton, who is the Dean of Public Health at NYU, said that there has been an explosion, in the best sense of the word, in the interest in public health as a field of study since COVID, and so they've tripled the applications to graduate school. Now that may not be sustained over time, but the intersection of public health and medicine. Do you want to comment on that?
Sure, David. We haven't met. You're very thoughtful, and you're absolutely right on. Yes, the intersection of public health and medicine is really interesting in the sense that I have a PhD. And my expertise is in medical sociology, expertise in artificial intelligence and large data sets. And my career has been very international, so I'm very used to debriefing ideas in different parts of the world. So the one team I was on, 342 of us produced the World Report on Disability, co-funded by the World Bank and the World Health Organization, debriefed in Manila, Rome, Washington, D.C., Tokyo, and South Africa. And where you go out, send them ahead of time and listen. So what's going to happen now, if you take a look, is people like the next generation of Petos and Faucis and Haas and Piats and so forth, myself. Today I'd be an MD, PhD with field work internationally. In those days, that's not what you did. So what you're seeing now, and this is your friend at NYU, is MD PhDs with field work in the inner cities of the United States or on the border with Mexico, and field work in other countries in the world, working in international teams. So when I went out on WHO teams and worked with people, we went out on a team and you couldn't have more than 2 Americans or 2 British on the team, which meant in an 8 or 10 person team, you had 7 countries represented. That's where we are now. And that's where we ought to be. So this Walter Isaacson book I mentioned to you, The Codebreaker, the American woman who won, and it's a wonderful person, she's in her 50s, is Jennifer Doudna. Her co-worker and the other woman who won with her is Emmanuelle Charpentier. And Emmanuelle Charpentier had a lot of her career at Institut Pasteur Paris. Both of these women have studied feet on the ground in over 4 countries, working with the best people in the world. David, that's where we are. That's where the science is. That's where medicine is. That's where public health is.
And I apologize, but I need to be on another call here in 2 minutes. So, but Gary, maybe I can get your information from Josh and we can continue this conversation. Really enjoyed your presentation.
And I really enjoyed your question. Thank you.
Thank you.
Eric, did you have our last question for the day?
Oh, last. Thank you. I didn't know that if it was the last, but Gary, thank you very much. It was very informative. Something that I wanted to ask, you were talking about the psychological aspect, how the COVID and pandemics can change psychologically, you know, a country and the people and how they think. I mean, what is your thoughts about, I mean, I lived in Russia for many years, for close to 25 years, and they have socialized medicine. And so, you know, America is very different, or you have to basically pay to go. And it's interesting to see here that, you know, like the COVID tests, the vaccines, they're all, I mean, you're not paying for them. People aren't paying for them. They're given by the government, or they're paid for by the government. Do you think that this experience that America is going through with COVID, where the government stepping up and taking more responsibility and covering a lot of the costs, might lead to sort of a psychological shift towards America finally getting some kind of, at least, you know, to complement private insurance, some kind of socialized medicine that covers all ages instead of just from 65 and above?
A really thoughtful question. So yes, I think it will, but it's a very uphill battle. So the first thing I wanted to say, from 25 years in Russia, my hat's off to you. I've worked with the Russian Academy of Sciences over the years, pre and post Iron Curtain. The Russian scientists are absolutely first rate. In biology and medicine, they're really good. Some of the people at Novosibirsk and so forth, these vaccines they've produced are really good. And the Chinese vaccines are really good. So what I'm saying to you, and you have 25 years of experience somewhere else, the rest of the world are not idiots. And they have a long background of very, very good people. If you can, would I get a Russian or a Chinese vaccine? Sure, I would.
My mother-in-law took it, so, and a lot of my friends did. So
okay, so then moving to the United States, here's the problem. And I want to pick something. I wrote a book on the political economy of healthcare in the 1990s. The disability business, rehabilitation in America. And one of the principles in my book was Rick Scott. You know Scott from Florida?
Mm-hmm.
He made his money, hundreds of millions, as chairman and CEO of Hospital Corporation of America. Then he became a governor. Then he became a senator. And then he became, that's who you're fighting. Where did he get his hundreds of millions of dollars? Who's going to vote on American healthcare? Who? And so you know the game. So we have experienced healthcare, consuming it in numerous other countries. Huh?
Yes.
And what I would say, at least my feeling is this, is the best healthcare in the world in the United States. There's some very good healthcare. Some of the best people in the United States. But in terms of populations and for the good of the country, national health insurance is it. And we have it in terms of our VA system is national health insurance. We have it. How many of you here are old enough to have Medicare? I am. How many of you want to give it up? If you ask that in an audience of 1,000 old people, nobody's going to raise their hand. And so what you can do to that, this is national health insurance in England. This is national health insurance in Canada. There's upsides and downsides, but in general, what you want, if you're you and I and have money, you want national health insurance, then you want to buy a private policy to top that up. So if you should like, you can jump queue or go to another country to get care. So
that's what Russia has.
That's what Russia has.
Yeah.
But we have that. And I just had hip surgery 3 years ago. Where did I have it done? In Belgium. And I wrote a check for 14,000 euros to have hip replacement surgery by, I think, one of the top people in the world who does that. That's all he does. People come from all over the world to go to him. And what did that do? I had insurance, didn't pay any of it, $14,000. It paid for me to have my x-rays here in Boulder, Colorado. Those sent to Belgium electronically to Ghent, University of Ghent. It paid, it didn't cost, then I went to Ghent, had pre-op, had surgery, 3 days in the hospital, 1 week in a 4-star hotel with a nurse and a physical therapist on your floor, all the drugs, discharged to our apartment, and a physical therapist come 5 days a week for 2 hours a day to give me physical therapy. No copay. I had to sign 2 pieces of paper to execute that. And I say, that's not the experience I have in the United States.
I
What
have
was the
social medicine
$14,000
in
for?
Russia.
What?
I'm sorry.
What was the $14,000 for?
14,000 euros. It paid for all of that.
Right, but you paid it out of your pocket.
Yes, I wrote a check.
Well, in Russia, you have socialized medicine, and my employer provided, though I was the employer, but we got a private health insurance plan, and for a family of 4 that I am, it was $5,000 annually to have that additional private insurance that complemented the social medicine. And so, I mean, Kaiser here, I'll just share it. I mean, family of 4, I'm paying 30 grand a year, and so I mean, it's just amazing the difference.
Yeah, if you're in business and do that, it's the cost benefit ratio. What am I getting for what am I giving? And then I ask myself, it's income tax season, guys, is how much of my time am I spending on this?
Yeah.
What if I just reported income and wrote a check for 15% of my income to the government?
Yeah.
I just saved a couple of months worth of work.
Yeah.
So the answer to your question is yes, it will put all those pressures, but no, the system's not going to change because there's too many people in power that have too much invested.
Thank you.
Great. If anybody wants to stay on a little longer, we can have more conversation. This has been thrilling. Gary, thank you so much for sharing so much. You brought human touch to an amazing world of science and human behavior that for me, I've never been exposed to. So I really appreciate that. And thank you all for joining us today. I want to share that next week, we have another one of these sessions with Nia Wasink with the nice title of The Problem with Philanthropy in Boulder County. So please sign up for that and join and see where Nia is going to take us on that. But Gary, you're such a treasure to have as part of our partnership. And thank you for sharing your mind with us today.
Thank you.
Thank you.
Thank all of you.
Thanks, Gary.